I'm Dr. Edward Healy, Chief of Cardiology at Suburban Hospital in Bethesda, Maryland. Due to some recent events, expectant mothers in Washington, D.C.'s most vulnerable areas are facing a significant healthcare crisis. United Medical Center from Ward 8 and Providence Hospital in Ward 5 are both closing their maternity services. Both of these hospitals were already underperforming, having received only 1 star, the lowest rating, from CMS hospital ratings. Additionally, others may be losing access to the city's largest hospital, Washington Hospital Center. MedStar, which owns Washington Hospital Center, has recently lost its contract with DC Medicaid services. Although there are ways for patients of MedStar hospitals to continue to use them through Medicaid, this is a difficult task and may be hard for Washington, D.C.'s poorest population. In addition, D.C. has a striking disparity. The mostly white residents of Ward 3, the wealthiest ward in D.C., have an infant mortality rate of 1.2, on par with the wealthiest and healthiest cities in the world, while Ward 8, predominantly African American, had a rate of nearly 15, similar to what is seen in Central America and Southeast Asia. Recently, the district has grown more affluent, but rising housing prices have put economic pressure on long-term district residents. This background and the social determinants of health is the framework within which the current prenatal care crisis is occurring.
Hi, I'm Monique Sanfuentes, Administrative Director of Community Affairs and Population Health Improvement at Suburban Hospital. While there are a number of community clinics around the city that provide prenatal services, there is still concern over how prenatal care is coordinated between the clinic and a delivery hospital that may be part of a different network. Such hurdles are likely to impede quality and continuity of care. The district's poorest residents have no other choice but to travel far outside their neighborhoods for prenatal and maternity care.
I'm Larry Ramunno. I'm the Chief Medical Officer at Sibley Memorial Hospital. I think it's an entry vehicle. The way I always imagined it is that we would be able to essentially test where a good place would be to put a brick and mortar clinic, thinking through how would you actually do this, and how big is the van, and how big could the offices be, that kind of stuff. You got to sort of think through that stuff. You just can't have an empty room. You have an exam room, and you got to have some stuff. But the vans are pretty significant, and you can have internet connectivity, so you could use the electronic record.
Hello, I'm Pete Shaffer. I'm a marketing manager for a biotech company. Well, there's definitely an opportunity to benchmark with some local successful programs with mobile caravans and mobile health clinics. One is in Montgomery County. They have the mobile med clinics, and there's certainly opportunities to work with them to figure out the best way to implement.
So my name is Kathy Luton. I'm a nurse practitioner and the clinical director at Mobile Medical Care. We have 11 locations in Montgomery County, Maryland. We're a federally qualified health center, and we also have the homeless shelter contract for Montgomery County. I became involved about 5 years ago and have provided hopefully leadership and guidance to the staff here. There's a staff of about 35 people. We try to go where people are. Most of our patients don't have cars, so we have to be on public transportation lines. We have to have a site that has a bathroom so that patients can provide specimens if necessary. We have to have a place to be able to park. It's a pretty big van, so we need that capability. There needs to be some parking locations, and we are on the bus route. So this met all of the criteria. In low-income areas, a lot of times people come and go. If there's trust and consistency, then it works out better. We have the maternity partnership in Montgomery County provides prenatal care and delivery for patients who live in Montgomery County. We provide them with that. We get patients screening mammograms, screening colonoscopies, preventative health care. So the mobile van is a good business model to get things started, but I wouldn't call it an end game. I would call it a way to see what locations work better than other locations, to see how many personnel you need at various locations.
My name is Glen Lam, and I'm a healthcare IT consultant. In 2013, the total number of births in DC was over 9,000, with wards 5, 7, and 8 accounting for 44% of that total. That means mothers for 44% of the total births in DC must now travel outside of their ward to their nearest hospital labor and delivery center at Howard University Hospital. This amounts to travel time of about 30 minutes at best, or 40 plus minutes with public transit. Located in Ward 8, United Medical Center is the only full-service hospital in the area and serves both Ward 7 and 8. According to the U.S. Census Bureau data from 2015, the residents in these wards had per capita income of $22,000 and $17,000 respectively. We can compare those numbers with residents who live in Ward 4, which had the second highest birth count and per capita income of $43,000. This shows us that extra pressure will be put on the residents that are already struggling to live above the poverty line. Looking at data provided by DC's Department of Health, it shows that wards 2 and 3 have the lowest birth count. However, it is these wards with the greatest number of labor and delivery beds. Even though DC as a whole has the labor and delivery capacity, the geographical makeup is heavily skewed away from areas of the district with lower per capita income.
Recently, the Community Health and Wellness team at Sibley Memorial Hospital conducted community conversations with members of Ward 7 and 8. I would like to share a few powerful conversations with community members. The stories, concerns, and insights are compelling. Care and services are desired close to home in a culturally competent way, discussing and addressing challenges in the context of daily life. Life east of the river can often have higher cost, even though not all costs are financial. For example, the cost of trying a new food, like eggplant, feels high. If you've never cooked it, why would you risk spending the money and throwing it away versus spending your money on a less healthy option that you already know you like canned food or fast food? There is a feeling that the threads of life are more tightly connected. When one thread is pulled, it tugs against every other part of life. For instance, getting sick may mean missing work, which may be the difference between paying rent or losing your home. When the fabric of life is so tightly woven, even small challenges can impact the rest of your life.
Certainly, this population has historically received poor prenatal care, and that coupled with a reality that malpractice rates and malpractice events in DC are very high, and it's been established that by providing very good prenatal care, we can lower the malpractice risk. We also need to figure out a mechanism to provide hospital care for these patients, and we think a good opportunity for this is to do it at George Washington University Hospital for two reasons. One particularly is that it's within a drivable distance from Ward 7 and 8. And second of all, the nurse practitioner service at George Washington may be able to provide a laborist service. So in summary, we think we can not only deliver better care, but we can do it cheaper, deploying this model and using the mobile van as the launching point.
And the three funding sources really seek payment and reimbursement through Medicaid services, specifically the DC Medicaid, but also Amerigroups, the DC HMOs. The second funding source could be charitable or grant donations from large corporations that are interested in our mission of helping women and babies. And then the third piece would be really private donations from the individuals, as well as different service organizations, for example, the United Way, or local charitable organizations that would be willing to help support the Caravan.
So we'd like to bring care needed to patients in Wards 7 and 8 in addition to prenatal care, extending it to primary care and behavioral health care. Now, this may seem like a stretch, but this has been accomplished in the United States. at a place called South Central Foundation in Alaska, of all places. They've been able to exceed the rankings above the 90th percentile for many measures in what's called the Healthcare Effectiveness Data and Information Center, HEDIS. And they've been able to improve care in behavioral health patients receiving same-day consultations. And they've had to deploy it across a much larger area. By adopting this model using the mobile van, we should be able to not only meet the patients where they live and address their social determinants, but also scale delivery of prenatal care and expand it to primary care and behavioral health care integrated for the population.
Was that too newsready?
It was a little bit like you were definitely reading.
Okay.
You
I
think?
better.
Okay.
Yeah.
I think we should do that again.
Okay.
So funny.
Okay.
Is it even working?
Yeah, okay. What are some potential partnerships for the Caring Caravan?
Hope Maisie doesn't run through the shot.
And integrated behavioral health care, you're right, it's going a little too fast.
Okay.
All right. That was a lot better.
Yes.
Good. Okay.